So I'm now talking about the pediatric hematology. It actually is quite a big workshop, and it's actually divided into 3 parts: red cells, white cells, and platelets. So I'm starting off with just something that's a bit not in the right order, but it's something that's very important. And I'm just showing you 2 slides of normal lymphocytes in a 1-day-old neonate. So a neonate is the first 4 weeks of life, and this is just a 1-day-old to show you these are lymphocytes and normal for a 1-day-old. This one you'd probably be happy with, but this lymphocyte here has got a high NC ratio. Perhaps the chromatin pattern's a little bit more fine, but it's actually normal for a 1-day-old neonate. So that's just something to be really mindful of. This is another image here just showing the same thing. Very high NC ratio. It is not a blast, and neonates do not have blasts on their blood film. That's something very important. So basically, this shows you the development of hemopoiesis as we go through development. So basically, the first cells are produced, which are produced in the mesenchyme area. They're really the red cells, and that extends for the first 3 months of life. And then if you look at the spleen, cells are produced in the spleen between about 3 and 6 or 6.5 months. In the liver from about 1.5 months going on into birth. And of course the last section is in the bone marrow from about 4 gestational months and continuing on into adult life. And this is a very useful chart to keep in mind. This comes from an American textbook by Nathan and Oski, and I think it's very useful because it just shows you what's happening to mainly I would take notice of the mean cell volume and the reticulocyte count and see how they're very high in the very premature or early gestational age. For about 24 to 25 weeks, you've got a very high mean cell volume and a very high reticulocyte count. And then you can see that that gradually goes down as we go through gestation. And this is the final term results that you get. For the retic, it's usually 4 to 7%. And the MCV is very high. So it's still high, but not as high as in the first few weeks, 24 to 25 weeks gestation. So that's something to be mindful of. So sometimes you get to be, you're asked to look at a blood film from an infant, and they don't actually tell you how premature it is. But if you knew how many weeks gestation it was, you know what to expect to find with the MCV and the reticulocyte count. So that's quite useful. This just shows you the different types of hemoglobin and when they start to be produced. So this isn't anything that I would be worrying too much about. Here we're really starting on the real things that you need to be very au fait with. So it's first thing is the red cell lifespan in days. So in an adult, I'm sure everyone knows the lifespan of the red cells is approximately 120 days. In a term infant, the lifespan is 90 days approximately, and a premature infant, depending on the degree of prematurity, is between 45 and 70 days. So this is important because you may be looking at a blood film of, and you may be given that information of a premature baby, and you may find that that baby is tending to be anemic, MCV is high, retic count's high, but you don't see any reason to think why are they anemic, so when you're looking hard, you see nothing on the film that helps you. So if you knew the degree of prematurity, you would know that the lifespan of the red cells is much shorter. So therefore, there's no need to worry to try and make a diagnosis. It's simply because it's a premature baby with a shortened lifespan of the red cells. Also looking at the neonatal red cell membrane, pardon me. If you're looking at an adult, which you would be au fait with, you know that about 78% of the red cells are discocytes or biconcave discs, 18% are bowl forms, and 4% are poikilocytes. And a poikilocyte is any red cell that is not a biconcave disc. It's not specific, doesn't tell you anything about the shape of the red cell. In a term infant, 43% are discocytes, 40% are bowl forms, and 17% are poikilocytes. And in the premature baby or premature infant, 40% are discocytes, 30% are bowl forms, and 30% are poikilocytes. And so the poikilocytes on these two, the premature and the term baby, basically you may get target cells. It may be that the liver is slightly immature, so you get some target cells, and you will definitely get some spherocytes, just an occasional spherocyte, certainly no more than a mild number of spherocytes. And if you see those, take no notice. It basically means that it's a minor ABO incompatibility. Of course, if you start to see moderate numbers of spherocytes, then you should be aware that you may be looking at an ABO incompatibility. And we'll talk about that a little bit later. So this is a little bit of interesting trivia. If a baby is under 12 months of age, they're bled from the plantar surface of the heel, this area here. And if they're over 12 months of age, they're bled from the palmar surface of the third or fourth digit of the hand. And these slides, as you can probably see, are quite old. So this comes from a very, very long time ago when I started to do pediatric workshops. And that's why the person taking the blood isn't wearing gloves. And so bleeding from the heel, this is the process where they have to give a fairly good puncture so that they get a good flow of blood into the capillary tube, just by gently squeezing and releasing and squeezing and releasing the heel. Taking blood from the older child over 12 months of age. This is taken from the finger prick here. This is the guard, and basically a good prick again from the finger and squeezing and releasing so that you get a good flow of blood. And if you do prick well, and you know a solid prick, you should get a good flow of blood, and you should get an accurate platelet count. Now, there are certain factors which influence the hematological values at birth. One is the gestational age of the infant, so that you could then refer back to the Nathan and Oski chart and see what you would expect to find at the number of weeks gestation. Second is the conduct of labor. Of course, if the baby is born by a normal vaginal birth, that baby will have a very high white cell count with an absolute neutrophilia, because the baby has had to work hard, just as hard as the mother has had to work. If the baby is born by cesarean section, just gently lifted out, you would find that the white cell count would be lower and that you would get more lymphocytes than neutrophils. So the treatment of the umbilical vessels. So I do have a very good friend who's an obstetrician and who's given me a few tips for this lecture. And this is one of them. So when the umbilical cord is clamped, it is very important that the baby is held within 30 centimeters above or below the level of the mother. So if the cord is clamped when the baby is held too high, blood will flow back into the placenta, and therefore the baby will be slightly anemic. And if the cord is clamped while the baby is held too low, blood will flow back into the baby, and it'll have a falsely high or an elevated hemoglobin or red cell count. And the site of sampling is important. basically, if you have capillary blood, usually the hemoglobin and the red cell count is usually a little bit higher than the venous sample. We have a lot of blood counts done on children here at the Prince of Wales Hospital and on babies, and we actually don't define whether the blood is capillary or venous blood. So I don't think you need to worry too much about that. So we're talking about red cells, and in each section, I'm giving you the reference ranges. So the reference ranges are very, there's really too much to remember when you're trying to remember the reference ranges. So if you basically go to the next slide here, I've emphasized what I feel is important, going from 0 days to 12 years. So the ranges range up to puberty. So pediatric ranges should always end at 12 years. Now, these are really, truly genuine Australian ranges. They're not coming from a textbook, and they're made up, I have got about over 100 data points in these ranges. And I've also got 75 cord bloods, because at the time I was setting up these ranges, the Children's Hospital, Sydney Children's Hospital, was setting up a cord blood bank. So basically 75 cord blood ranges. So although we didn't publish these ranges, I think they're very good and reliable ranges, over 100, I think. Okay, so what's important to know is that when the baby is born, the mean cell volume ranges from 101 to 117. And that over time gradually reduces. So the hemoglobin goes down as well. The mean cell volume goes down as well. And from about after about 6 months, you'll find that the red cells actually are microcytic and hypochromic. So the MCH follows suit with the MCV. And even up to 12 years of age, the child could be slightly microcytic and hypochromic. So I think an easy way to remember these ranges, because it's a very busy chart, what I do is I remember from 0 to 3 months, the red cells are macrocytic and normochromic. From 3 to 6 months, they're either normochromic, normocytic, or starting to become microcytic and hypochromic. From 6 months to 5 years, they're definitely going to be microcytic and hypochromic. As I said, it can be microcytic up to 12 years. And then I like to think up to 5 years, it's definitely going to be microcytic and hypochromic. And then from 5 years, it's starting to become back up to normochromic and normocytic. And that's an easy way to remember the reference ranges in red cells. Reticulocytes. These reticulocyte ranges come again from Nathan and Oski. So you can see the reticulocyte count is very high in the very immature 24 to 25 weeks gestation, and is still high at term. Our ranges, which were just estimated after we'd done the reference ranges, we didn't do reference ranges specifically for reticulocytes, but in cord blood, definitely 3 to 7% was the reference range. And at the end of day 1, it's the same, and then the retic count just gradually goes down. So by the end of the first week, you should find the reticulocyte count is 0 to 1%. So 3 to 7% when the baby's born, and then by the end of the first week, down to 0 to 1%. And that's very important to remember that. So now I'm going to talk about anemia in the neonate, and we're going to talk about different stages or different mechanisms. So number one, hemorrhage, hemolysis, and impaired red cell production. So if we consider hemorrhage, we should consider in a newborn infant, we should consider it could be an obstetric accident. It could be an occult hemorrhage prior to birth. So it could be a feto-maternal bleed, or it could be a twin-to-twin bleed. If we're thinking about hemolysis, we need to think about immune hemolysis. So we need to consider an Rh incompatibility, an ABO incompatibility, or a drug-induced hemolytic anemia, even at that very immature age. I'll explain that to you. It could be secondary to infection, it could be bacterial or viral, and it could even be a microangiopathic hemolytic anemia. And if that was the case in a newborn baby, it's very unusual, but it could be secondary to renal artery stenosis or severe coarctation of the aorta, so narrowing of the aorta. So if you've got a very narrow vessel, you can get a microangiopathic hemolytic anemia, and you'll start to see schistocytes on the film. But I've only seen maybe 1 or 2 cases of this, so I can tell you it is actually very unusual, very rare, but normally the history will alert you to the fact. So if we're thinking about hemolysis and then hereditary disorders, we should consider hereditary spherocytosis, and you can pick that in the first few days of life. Hereditary elliptocytosis and hereditary stomatocytosis, that's actually quite unusual. And then there's a red cell enzyme deficiency. So if you've got a baby who's for no other reason that it's anemic and with a low red cell count, then the consultants will usually consider this be an enzyme deficiency. And the 2 ones that they test for initially are glucose-6-phosphate dehydrogenase and pyruvate kinase deficiency. And then there's impaired red cell production. So there's a syndrome called the Diamond-Blackfan Syndrome, which is a pure red cell aplasia. So you may get a very young infant or a very young child come in with a severe anemia, and basically you might expect, if the anemia is so severe, you'd expect to have a higher reticulocyte count. But in these children with Diamond-Blackfan anemia, it's actually a pure red cell aplasia, so they don't have a raised reticulocyte count. This is unusual, quite not very common, congenital sideroblastic anemia. And then something else which is quite sad is a bone marrow replacement. So there are certain tumors that occur in young children. For example, neuroblastoma. Neuroblastoma can actually occur in utero, so the baby's born with this tumor. And of course, when you've got a malignant tumor replacing the normal bone marrow hematopoietic tissue, you'll find that the red cell count will be low. So I'm now going to give you some examples. This is a twin-to-twin. So the twin-to-twin hemorrhage occurs in monozygotic multiple pregnancies where there's a single placenta. So the anemic twin may have a very low hemoglobin. It can be as low as 35 grams per liter. It's going to be pale and weak, and it's going to have cardiac failure. The polycythemic twin, which has actually got a very high hemoglobin, can go up to about 300 grams per liter. It develops the hyperviscosity syndrome. Now, this particular talk was, I've given this for many, many years, and one of the consultants in Pediatric said to me that he wasn't too sure that the polycythemic twin would necessarily have a high bilirubin. But should the twin-to-twin hemorrhage be a gradual one, there will be a significant difference in the birth weight of the two twins. So I just want to go back to the previous slide. Some information from my obstetrician friend says basically your anemic twin will be very pale, weak, and have cardiac failure, a hemoglobin as low as 35 grams per liter. So the obstetrician says that's fine, I can transfuse that anemic twin and it'll turn from a very pale floppy doll into nice and pink, and it'll be fine. But it's the polycythemic twin who's got that very high hemoglobin, and it's got the hyperviscosity syndrome. That's the twin that is in danger. He explained it to me by saying that twin is pumping treacle through its veins, and it is at risk. That's why it's one of the results that you should ring through urgently to a consultant, I would think, rather than to just anybody in the ward or in the neonatal care unit, to let them know of the hemoglobin, because that twin is in danger. They have to get that hemoglobin and hematocrit down. So this is the twin-to-twin bleed. This is an anemic twin that we had quite some time ago. This hemoglobin on this twin was 29 grams per liter. So you can see it's trying very hard to compensate for the anemia. So the nucleated red cell count is very, very high. You would not expect to have more than 26% nucleated red cells per 100 white cells in a normal neonate. And there's a lot of polychromasia. And you might think that, oh dear, that's not a very nice looking film. It's the red cells all looked a bit knocked around, but you're not going to get a beautiful film with an infant with a hemoglobin of 21 grams per liter. So that's your anemic twin. And this was the polycythemic twin in this case, and the hemoglobin was 260 grams per liter. And I took this blood film, this is all times 1,000 magnification, by the way, and this blood film was taken right towards the tail of the film, trying to see if I could see some individual red cells, but they're all overlapping because of that very high red cell count and hemoglobin. And that's just a nucleated red cell that I put in that picture. So cord blood, just to make sure that you know what to expect to find in cord blood. So during the 3rd trimester of pregnancy, the red cell production progresses at a rate of 3 to 5 times that of an adult. And this rapid turnover in red cell production results in fewer red cell divisions. Hence, the red cells are macrocytic, with an MCV ranging in size from 101 to 117 femtoliters. And that's in our hand. So the number of nucleated red cells at term ranges from 1 to 24 per 100 white cells. The reticulocyte count ranges from 3 to 7%. The blood film is characteristically macrocytic with polychromasia, and in some cases an occasional target cell, as I said, because they may have a slightly immature liver, spherocytes because they've got a very minor ABO incompatibility, and the nucleated red cells. You will see, I think I might have said 1 to 26, but it's 1 to 24 nucleated red cells per 100 white cells, and Hal Jolly bodies may be present. Usually you would expect that the Hal Jolly bodies would not be there on a film of a 1-month-old baby, for example. And this is a cord blood film. So you can see that the red cells are macrocytic. There's an occasional polychromatic cell here and here's the reticulocyte count. I'm just looking at this film to see if I can see some crenated cells. I do talk about this a little bit later, but when you squeeze the blood out of the umbilical cord, you may sort of get crenated cells present. And at this time, I want to say to you, do not report on crenated cells. Do not ever, whether it's children, whatever age group. Pronated cells are an artifact. So when you're squeezing the blood out of the umbilical cord, it's not uncommon that you will get some pronated cells, and you should not ever report them. Okay, so now we're looking at an ABO, hemolytic disease of the newborn. So this occurs most commonly in blood group O mothers and affects babies of group A and group B. So the chief clinical manifestation is jaundice within the first 24 hours of life. And often you'll see on the request form from the clinician, jaundice, 24 hours of life, wondering what the cause is. And the hemoglobin concentration is usually normal in an ABO incompatibility. Can be a little bit low, but it's normal, usually normal. So the blood film shows increased numbers of spherocytes, and they stand out against a background of normochromic round macrocytes. And the degree of polychromasia may be increased. The direct antiglobulin test or the DAT test will be either negative or weakly positive. It's probably not necessary, I'll just go back a slide, to do a direct antiglobulin test. If you see a lot of spherocytes on the film, I would always say to whoever was looking at that film, just take the blood into the blood bank and get them, and take the baby's blood into the blood bank and get them to do the group on the baby. So the baby's going to be group A or B, and then the blood bank transfusion person will be able to look up the medical record number of the mother and find that the mother is group O. So what's happened is the mother is group O, so if she's O, then anti-A has crossed the placenta and gently coated the baby's A red cells, and vice versa. If the mother's O and the baby's B, then the anti-B or the antibodies have just crossed the placenta and coated the baby's red cells. So no need to do a DAT. It's a group, if it's groups, work out that way. I guess the only time when it may be a little bit more difficult, you can pick at a very early age, you can pick an infant who has got hereditary spherocytosis. And I do recall a baby, I was waiting to see, I knew that the mother had hereditary spherocytosis and also the father, and they were first cousins. And the baby, I was waiting to see what the baby's cord blood looked like, and it had moderate numbers of, or even marked numbers of spherocytes on the film. So that's pretty unusual, especially in our country, because it's not actually, in Australia, it's not actually legal to marry your cousin, but this was an example. So I guess the differential diagnosis could be hereditary spherocytosis, but you need to know a little bit more about the parents to work that out. And this is an ABO incompatibility. It's actually not such a good example, I'm afraid, because it's quite anemic. Usually it's not anemic like this, but you can see that there are spherocytes on the blood film, and it's not just occasional. I would say there are mild number of spherocytes on this film, and the occasional nucleated red cell. So now on the contrary, the opposite, an RH, hemolytic disease of the newborn. That's quite a different blood picture. So when anti-D antibody present in a sensitized RH negative mother enters the fetal circulation, RH positive fetal cells are destroyed, giving rise to a hemolytic process known as RH, hemolytic disease of the newborn. And this will be obvious probably because maybe this baby might have had an intrauterine transfusion because it was so anemic, and that will be probably known to the blood bank. But you're going to see quite a different picture. So this hemolytic anemia is characterized by jaundice, low hemoglobin, usually lower than 140 grams per liter, and it will have a raised reticulocyte count, extremely raised. It can be much more than the 7%. It can go as high as 30 to 40%. And there'll be an increase in the number of nucleated red cells, several hundred nucleated red cells per 100 white cells. So probably the diagnosis would be known, and the direct antiglobulin test, of course, would be strongly positive. And spherocytes are usually not a feature of Rh hemolytic disease of the newborn. Now, something that might be good to know, that sometimes these babies who have got Rh hemolytic disease are actually transfused in utero, as I just mentioned. And so they may have even more than one transfusion, and you may find that you're looking at a normal, supposedly normal 1-day-old infant, and the MCV is normal. So the MCV might be 87 centiliters, and you might think, what's going on? So if you talk to your blood bank scientist, you'll know that that baby was transfused, obviously with adult blood, perhaps a couple of times. And so you need to think about all these scenarios and understand what's happening. This is what makes morphology really interesting. So yeah, that's happened to me a few times. So if they're not transfused, of course, the MCV are going to be very high, especially in Rh, because they're going to have a very high reticulocyte count. So it'll probably be extremely high. Here's a nice image of the Rh hemolytic disease of the newborn. And you can see the number of nucleated red cells in this image. So this is taken over with 100 oil magnification, 100 oil lens. And so this is actually 1,000 times magnification. So in this small area, there's a very high number of nucleated red cells. And there's some increase in polychromasia. You can see some of these cells are polychromatic, so they're reticulocytes. Remember, reticulocytes are slightly larger than normal cells. So this particular slide, a slide like this would be really worthwhile keeping in your collection if you have a pediatric, or if you have an obstetric ward, because you'll see all the stages of maturation of the red cell as it develops. So it's a really good example to do teaching. For example, this is a very basophilic erythroblast. So this is very immature. And as the hemoglobin, as the cells start to acquire hemoglobin, it goes from basophilic, these are two basophilic, to polychromatic. And then there's no orthochromatic ones, but you can see the change in the cytoplasm as the cell acquires hemoglobin. So it's a good teaching slide for that purpose. Okay, so I've just talked about ABO and Rh, hemolytic disease as a newborn. I've talked about a 1-day-old infant, and I'm now going to review a couple of other examples where you see a lot of nucleated red cells on a newborn baby, so a day-old baby. And I call this Erythroblastosis Fatalis for want of a better name. This is not a baby that's born that's really truly got erythroblastosis due to having hemoglobin baths, for example, and that would be probably a stillborn baby. So this is a normal baby that's got a lot of nucleated red cells. And so there are 4 clinical conditions that can give rise to this picture: birth asphyxia, respiratory distress syndrome, pulmonary hypertension, and meconian aspiration. So this is where the baby has defecated and inhaled its feces. So it's also going to be quite septic as well. In any of these 4 clinical scenarios, you will find that there will be an increased number in nucleated red cells, and also the baby will be severely thrombocytopenic. So the nucleated red cell count can go from 500 to 800 nucleated red cells, but you'll know it's not an Rh incompatibility. So that's something that, unless you're working with pediatrics, this frightens people. So often we get a film from a newborn baby referred to us with all these nucleated red cells. But interestingly enough, that nucleated red cell count will gradually go down and the platelet count will gradually come up. So after about 1 to 2 weeks, you really would know that this was the sort of blood picture that the baby had on day 1. So in this disorder, as I've said, the hemoglobin and the red cell count usually normal, reticulocyte count mildly elevated, but the DAT will be negative. So there's one more thing that you could consider, that you get a similar picture together with thrombocytopenia if it's secondary to an intrauterine infection. So if this is the case, one would think to do a torch screen on the infant as well as on the mother. And in case you're not aware of torch, so the T stands for toxoplasma, the R stands for rubella, the C for cytomegalovirus, and the H for herpes simplex, and then the O stands for any other congenital infection. One might consider syphilis that can cause a neonatal thrombocytopenia as well. And here's a nice example of erythroblastosis, Fatalis. You can see the platelet count there's no platelets on this field, in this field. It's got a high number of nucleated red cells, not quite like the Rh incompatibility, but this is a nice example to show you. Doesn't look like Rh, it's just got a very high nucleated red cell count. So that's where looking at the clinical notes is very important. If it says birth asphyxia, for example, or respiratory distress syndrome, then you know exactly what's going on, and there's no need to panic when you've got a very low platelet count. You've got a clinical cause for it. Now I'm just going to talk about iron deficiency anemia. So rapid accumulation of iron by the fetus during gestation, despite possible iron deficiency in the mother. So what that is saying to you is that newborn babies are basically like little parasites. If the mother's very iron deficient, it's nevertheless the baby grabs all the iron from the mother, and newborn babies are never born iron deficient. There is a change that occurs in the iron balance and the rate of erythropoiesis in the first few days after birth. And these changes coincide with oxygen supply to the lungs. So that's when you see, once the lungs are oxygenated, that's when you see that slightly lower drop in the hemoglobin in the MCV and the reticulocyte count. So they all fall. And iron in that process is actually absorbed by the reticular endothelial system of the baby, increasing the neonatal iron stores. So this reduction in erythropoiesis, it continues for about 6 to 8 weeks. And then after that, the reticulocyte count starts to increase. The hemoglobin increases to a value of about 125 grams per liter. And iron stored during this period is providing the infant for the first 6 months of life. So after this period, dietary iron is necessary to maintain a normal iron balance. So what I'm saying here is that you can see when you look at the ranges that the MCV drops and the MCH also drops. And this starts when the lungs are oxygenated. So iron is released and stored in the reticular endothelial system. So you've got that early period where the red cell count, MCV, is dropping. it then, after about 6 to 8 weeks, the MCV starts to go up, hemoglobin starts to go up. So that iron, that drop in red cell count and hemoglobin, is actually a process whereby the iron is stored in the reticular endothelial system and therefore is there for that child in those first few months of life to have enough iron. Now, I guess when a baby's breastfed, that's the best source of iron. So it's going to also have enough iron to last it for at least 6 months of life, together with this iron stored in the reticular endothelial system. After 6 months of life, probably they're not going to be breastfed after that. So they need iron from an external source. So they need to have a good diet because they've used up the iron in their reticular endothelial system and they're not being breastfed. So if they don't get that iron from an external source, then they can become very iron deficient. So babies normally, when you look at the ranges, have a microcytic hyperchromic blood picture, but their red cell distribution width is normal. So that will be one of the things that you need to notice when you're looking at their films after 6 months, that they've got a normal red cell distribution width. So they've basically got a hyperchromic microcytic anemia, but normal red cell distribution. If they are really iron deficient, you'll find that that RDW will be high, and you'll find that you'll probably get a lot of elliptocytes and even pencil cells. So this is a pencil cell here, which is usually a feature of a very severe iron deficiency. And a pencil cell has basically, it's called a pencil cell because the walls of the red cell, you can see, are parallel. So pencil cells are a feature of severe iron deficiency. And I put a small lymphocyte nucleus here. So the nucleus of the small lymphocyte nucleus is approximately 7 microns in diameter, which is the size of normal red cells. So you can see that these red cells are actually very microcytic when you can compare with the nucleus of the small lymphocyte. I put this image in just to show you. So if you had a picture like that last one with a very microcytic hyperchromic picture, iron deficient, and the patient was then given iron therapy, you will find after a few days, you'll get what you call a dimorphic blood picture. So you can see now that, again, looking at the small lymphocyte nucleus, there's still some microcytic red cells left, okay? But there are also some cells which are actually much larger. Now, if you look at your graphics on your analyzer, you'll see that even though there are large red cells there, they're not larger than the reference range. So this is what we call a dimorphic picture post-therapy, iron therapy. But we don't call these red cells, which are larger, macrocytes, because if you're looking at the histogram, you'll see that they're within the normal range. So you'd refer to this film as being dimorphic. You could refer to the fact that it was anisocytosis because the red cell distribution is obviously high, microcytes, hyperchromic microcytes, and then dimorphic blood film. Do not call these red cells macrocytes because you're bringing in a whole new disorder. Would be actually incorrect. So now I'm going through some of the abnormal hemoglobins, and you can pick some of these on a newborn baby. So hemoglobin S, which is an abnormal hemoglobin produced by the replacement of glutamic acid with valine at the 6th position on the beta chain. Hemoglobin S tray is clinically asymptomatic with a normal hemoglobin level as well as a normal blood picture. You're never going to pick the tray on the blood film. A hemoglobin SS, they get mild to moderate normochromic normocytic anemia with reticulocytosis, and sickle cells will be present on the blood film. So sickle cells are biconcave discs that, upon deoxygenation, change shape to become sickle-shaped. When that happens, they can, if they're in the fine capillaries of the body, especially in the spleen, they can block off those fine capillaries. So this process will give rise to what we might call an autosplenectomy, because we'll see features on the blood film such as Haut-Jolly bodies, Pappenheimer bodies, which are iron granules, target cells, and nucleated red cells, all features of a splenectomy. So if you consider that the sickle cells, when they're deoxygenated in the spleen, they block off those fine capillaries and basically cause little splenic deaths in the spleen. So you're going to get features of, it's not splenectomy, but it's autosplenectomy. So you understand why you get those features in someone who's got SS sickle cell trait. You'll see nothing unusual on the blood film. It's quite normal. And here's a case of sickle cell disease, hemoglobin SS in the blood film. And I've shown you here a red cell with the Haut-Jolly body, which is the last nuclear remnant left in the red cell. Here again, it's a Haut-Jolly body. And these are the sickle cells, which have got pointed ends, different from elliptocytes, whose ends are rounded. So hemoglobin E, it's an abnormal hemoglobin produced by the replacement of glutamic acid with lysine at position 26 on the beta chain, and it's found most commonly in Southeast Asia. Hemoglobin E trait, clinically asymptomatic, with a hemoglobin level around about 120 grams per litre or perhaps a bit higher. The red cell picture is just slightly microcytic and hyperchromic with an occasional target cell. So that's E trait. Hemoglobin EE is also clinically asymptomatic, but the blood film is very characteristic. The hemoglobin usually is around about 100 or less, 100 grams per litre or less, with a very low mean cell volume and mean cell hemoglobin, of course. And you get hyperchromic microcytes, but you get a marked number of target cells. So I just want to remind you, you will have looked at the red cell workshop where I've described the target cells, and I've described the fact that they have an increased surface area compared to volume. So just going back, if you've got, normally in a hemoglobin, forward. If you've got a hemoglobin E disease or hemoglobin EE, you will find that the MCV will be approximately 55, in the mid-50s femtoliters. So that is, and when you look at the film, so I'm telling you now that this MCV is 55 femtoliters, can you actually correlate the number of microcytes with an MCV of 55? No, of course you can't do that because there's hardly any. There's just marked targets on this film. Keeping in mind the targets have got an increased surface area compared to volume, which brings down your MCV. And this is a classical film here that you're looking at of hemoglobin EE. And then hemoglobin C, another one not so commonly of the abnormal hemoglobins. It's an abnormal hemoglobin produced by the replacement of glutamic acid with lysine at the 6th position of the beta chain. and it's found in West Africans, particularly from Ghana and the Upper Volta. And the hemoglobin C tray is clinically normal. You may see a few target cells in an otherwise normal blood film. But hemoglobin CC is associated with hemolytic anemia. So the red cells are mildly microcytic and hyperchromic with a moderate number of target cells. Now, if you're thinking you've got CC, you need to look very carefully at the red cells, because on careful examination, you'll see that there are some intra-erythrocytic crystals that dissolve readily when oxygen is released to the tissues in the red cells. So I've shown you a nice film. It doesn't look very nice, but hemoglobin CC will always look like this. And I'll just tell you, I remember when I first saw my first case of hemoglobin CC. In fact, this was probably it. And I looked at the red cells and I thought, no, there's something wrong here. There's an artifact in these red cells. And it was quite late in the evening. And I said, I'm not going to report on this film. I want to have a repeat, because this has actually come from another hospital, not so far away from our hospital. But I thought, I don't know what's happened to this blood. And so this is the repeat film where the red cells don't look really nice. And this is classically a hemoglobin CC. So I've shown you here, tried to depict a red cell which has got 3 crystals within the red cell in this. So these are the crystals of hemoglobin C found in hemoglobin CC or hemoglobin C disease. Now, I'm talking about hereditary spherocytosis. So these are all the possible things that you can see in a newborn, okay? I've only really seen CC in an adult, but I've certainly seen sickle cell. I've been asked by the clinician, Gillian, what do you think? Why is this baby so anemic? And if you look really very carefully, you will find some sickle cells on a newborn. So let's look at hereditary spherocytosis. Spherocytes are the result from an intracorpuscular red cell membrane defect. So your deficiency in spectrin, ankyrin, or band 3 protein leads to the uncoupling of the skeletal lipid bilayer, resulting in membrane loss in the form of microvesicles. So this loss of surface area leads to the formation of a spherocyte. And hereditary spherocytosis is characterized by red cells which lack an area of central pallor. They have a slightly smaller diameter than normal, with an intensely hemoglobinized. So the MCV and the MCH are within the normal range. So I've said they're slightly smaller. So if you work that out and think about it, the spherocytes are smaller, but because the patient will be anemic, you'll have an increase in reticulocytes to compensate for that anemia. So hence, with your increase in spherocytes and then reticulocytes, you'll find that your MCV and your MCH will usually be in the normal range. Sometimes you will find that the MCHC will be raised in hereditary spherocytosis. And that's fine. You know, your MCHC is your quality control parameter. And if that's normal, then you know that all your red cell parameters are within range. If it's high, then you need to think about why it's high and look at some of your red cell parameters. But in hereditary spherocytosis, it can be usually 360 grams is the upper limit. So if I knew that there were spherocytes on the blood film, I wouldn't start to look and find out why the MCH was high. I would know. I don't have to investigate the other parameters. This is the cord blood of the little baby, the neonate that was born to the 2 cousins who both had hereditary spherocytosis. So I think it's fascinating. I was looking and waiting for this baby to be born to see what the red cells looked like. And so there we go. I think we really got at least moderate to marked numbers of spherocytes, on this blood film. Some increase in polychromasia. So you really do need a good history to know that this is not an ABO incompatibility. Now I'm talking about some of the more rare disorders. And this is hereditary stomatocytosis. All right, now just keep concentrating. Stomatocytosis, not Southeast Asian ovalo or stomatocytosis. So there, in this case, we have a defect in the sodium-potassium exchange pump in this particular disorder. So there's an imbalance between the amount of sodium entering the red cell and the potassium exiting the red cell. And this leads to an increase in monovalent cation content, causing the movement of water into the red cells. So the red cells swell and they're transformed from discocytes to bowl forms. So when we use the term bowl forms, it means that it's not like a biconcave disc. So these bowl forms are known as stomatocytes. Now, I just must emphasize that this is extremely rare, very rare indeed. And so the MCV in true stomatocytosis, because they're more or less like waterlogged red cells, more sodium entering the cell than potassium exiting the cell, the MCV will be increased. So patients with hereditary stomatocytosis have hemolytic anemia, they're jaundiced, they have a splenomegaly, and they often develop pigment gallstones later on in life. And splenectomy, I'm now talking about an older patient, not a neonate or an infant. Splenectomy may diminish the rate of hemolysis in these patients. So if you take out the spleen, if you think about the spleen as being the organ in the body, which is like the garbage bin of the body, it pits out all the abnormal cells. And therefore, if you've got, for example, in our previous case of the hereditary spherocytosis, when that little baby gets older, it may have to have the spleen removed, because if you take the spleen out, the red cell count and the hemoglobin will be maintained, and that won't be so anemic. So it's basically the spleen which is removing all the abnormal cells, hence the spherocytes. And in this case, we've got stomatocytes. So now this is an amazing blood film. I did show you this in the red cell workshop, and I said that there'd be a better example coming up. So this is actually an adult. This is a 27-year-old male who was touring Australia from the UK, and he was in the CBD in Sydney, and he came into Sydney Hospital to have a check on his full blood count. And he came with him some results of one of the very old analyzers, the Technicon analyzer, which some of you may remember, showing that his MCV was indeed really very high. And he also came with a case study that had been written about his disorder. And I was truly fascinated because his MCV was like 130, and I understand it can go up to 150. When I looked at his blood film, yes, indeed, he had stomatocytes. You know, stomatocytes can be an artifact, but his MCV was 130. So he did have some reticulocytes, but he had some Hal-Jolly bodies, which was telling me that he'd had his spleen taken out. This is the last nuclear remnant here, which is a Hal-Jolly body. So I got quite excited, and I talked to somebody in one of the other Sydney hospitals who was a red cell expert. And he was also fascinated because he said, you know, there's only about 5 cases of this disorder in the world. And this gentleman was the son of the first Englishman, according to the case study that he brought with him, the son of the first Englishman who was diagnosed with hereditary stomatocytosis. Obviously, I took the blood, sent it to the QAP, but it was a long time ago. I don't know how long you keep your QAP slides, but you may find this blood film in that collection if you have done that. So that was talking about an older person. Going back now to oxidant hemolysis or non-immune hemolysis, which is commonly a feature of, can be a feature of very young children. So the use of oxidant drugs can be easily recognized from the blood film, provided the patient has not had a splenectomy. Okay, just reminding you, the spleen is like the garbage bin, removes all the abnormal cells from the blood. So if somebody has not had a splenectomy and they've got oxidant hemolysis, you're not going to see those changes on the blood film. So oxidant drugs denature the hemoglobin to produce Heinz bodies. So the iron is transformed from the ferrous to the ferric body, producing a Heinz body. And these Heinz bodies are removed and pitted out by the spleen. When that happens, some of the red cell content is also removed at the same time. So occasionally, should the red cell membrane after the Heinz body and some red cell content has been removed, should that red cell membrane join back up or rejoin, you will get a blister cell. So basically oxidant hemolysis, the term used to describe it is bite cells and blister cells present. So red cells of premature babies and neonates are susceptible to oxidants, and the more premature they are, the more susceptible they are. And that's actually because when they're very premature, their skin is very thin and they can absorb oxidants from the air. And so they can be more susceptible than compared with a term baby, although they're still susceptible, but nothing like the premature baby. So prolonged exposure to naphthalene will induce a hemolytic anemia in infants despite normal levels of the enzyme G6PD. So if they're lacking G6PD, you're really going to find a massive oxidant hemolysis picture, or lots of bite cells and blister cells if they're exposed to an oxidant. Right, so now this is a neonate. I can tell that because the red cells are in fact macrocytic. Okay, it's a bit anemic, but I'm looking at some of these cells and you need to look very carefully. You always look I think you look very carefully when you look carefully when you're looking at any blood film, but when you're looking at children and looking at the clinical notes, you need to think hard and be very vigilant about findings you see on the blood film. So these 3 cells here are what I would call bite cells. So they're a feature of oxidant hemolysis. And so this one here has got a few chunks taken out of it. So remember, when you've got a bite cell, it could have not just one Heinz body, it could have several Heinz bodies. It could have 5 Heinz bodies in the red cell. So you're going to get 5 bites and you're going to get a bit of some deposits of red cells, which you would not confuse for anything other than bites, but you need to be careful about that. Now this cell here is quite interesting because you can see that some of the red cell content has been pulled out when that Heinz body has been removed. All right. There's another one here. It's another one here. So these cells are not normal. Red cells on a normal neonate should look like this, macrocytic. So now I've just put this picture in just to show you. This is an example of a very interesting case. I explained to you, this was an adult who had SLE, systemic lupus erythematosus, and she had a very low platelet count. She was one of our what we call special hematology patients. And for years, her platelet count was sort of running at about less than 10, like 10 to the 9th per litre. So the hematologist decided had to get the platelet count up. And whatever they did, whatever drugs they gave her to get the platelet count up, it didn't come up. So the surgeon, very clever surgeon, took her spleen out with a platelet count of less than 10. And still her platelet count wouldn't come up. So unknown to us, one day when they're making the blood films on this lady, someone said to me, so this blood is brown, the red cells are brown. I said, red cells that don't look brown in the EDTA tube, but indeed they were brown. So I suggested that we actually do a manual retic preparation. So we add crystal blue and incubate the red cells at 37 degrees. I think this was for 20 minutes. And we looked at the film, and this is what we found. So in fact, she'd had her spleen taken out, and she had lots and lots of Heinz bodies in her film. So these are the Heinz bodies, but they're not being removed because she's got no spleen, so she's got no bite cells or blister cells. And she, in fact, was on the drug dapsone. And dapsone is used to get the platelet count coming up. It's one of those drugs that makes the platelet count come up. And so there you are. So we had to tell the clinician, so-and-so had all these Heinz bodies on the blood film. Of course, I guess he must have reduced the amount of Oxidant or dapsone that he was giving her. So that's what Heinz bodies look like. And of course, they're only going to be stained if you use a supravital stain. So supravital is a stain that stains living cells. And the best stain, this is a crystal blue preparation. The best stain to stain Heinz bodies will be methyl violet because it only stains Heinz bodies. The crystal blue will stain Jolly bodies. It will stain reticulocytes. So I don't know if you can see this on the PowerPoint presentation, but this cell here, it's got a Heinz body in it, but it's got some RNA, so it's staining up a reticulocyte. So I don't like the stain methyl violet because you don't get really nice looking, crisp looking red cells. So that's the story about this one. So now thinking about glucose 6 dehydrogenase deficiency, if you happen to be G6PD and you're susceptible and you're given an oxidant, then you're going to get a lot of bite cells and blister cells on your film. So G6PD is the enzyme controlling the first step in a chain of reactions that constitute the pentose phosphate pathway. And patients with G6PD deficiency are clinically and hematologically normal until subjected to an oxidative challenge, either in the form of an oxidant drug or, and people tend to forget this maybe, after the ingestion of fava beans. Fava beans are broad beans which act as an oxidant. So either of these challenges induce an acute hemolytic anemia. So if you're G6PD deficient and, for example, you eat fava beans, or which are snacks in some of the big supermarkets currently, within 6 to 24 hours, the patient will be passing dark urine and the hemoglobin level can drop significantly. And when you look at the blood film, you show marked numbers of bite cells and blister cells on the film. And here's a case of a patient who was G6PD deficient see how anemic this patient is, and see how you can see this is showing you these blister cells present here. There's another blister cell here, another blister cell here. Not so many bite cells on this particular example. Now I want to just make sure you understand all of this. What I want to say to you is, and people do comment sometimes on a patient with oxidant hemolysis and they report spherocytes. Do you think that would be correct? I can tell you it's not correct. If you report spherocytes with a membrane defect, you're introducing a whole new disorder. So if this blister cell here, or this one perhaps here, landed upside down on the glass slide, all you would see is this, a bowl shape here, which was hypochromic, and it would look like a spherocyte. So my advice to you is to be very, remember this workshop. Basically, spherocytes are not a feature of oxidant hemolysis. So now pyruvate kinase deficiency. So pyruvate kinase is the erythrocyte glycolytic enzyme involved in the Embden-Meyerhoff pathway of metabolism. Deficiency of this enzyme is associated with chronic hemolysis, thus the patients are anemic, they have jaundice and a large spleen. In some cases, the anemia may be profound, presenting in early infancy and requiring frequent blood transfusions. So that's why this enzyme is sort of when they are anemic in the very early stages of life. They test for PK deficiency. So in other cases, the anemia other cases where they're also PK deficient, the anemia may be only mild. So the deficiency may not be discovered until late childhood or even adulthood. And the blood film shows a red cell picture consistent with that of a hemolytic anemia with an occasional prickle cell. The number of prickle cells is strikingly increased following splenectomy. Now, prickle cell, I must say, as being the author, one of the authors of the my CSH document on the standardization of nomenclature for red cells, prickle cell was not a cell that they wanted to use. Although if you look at atlases written by English hematologists, they all use the term prickle cell. And I cannot explain to you exactly how the prickle cell becomes to be a prickle cell. But I'm going to show you a couple of images now. So this is a case of a very young child that had PK deficiency. And you can see the red cells are basically completely normal. You would not know except that they'd be anemic. And then I found this cell on the film, which I couldn't account for. And I thought to myself, well, this could be a prickle cell, because we knew that this child had PK deficiency. So I would not even try to find this. I spent a long time trying to find a cell like this. So when they get older, the children get older as an adult, or you can't really have your spleen taken out until you're about 8 years of age. They then take the spleen out. Now that treatment may be different now, but this is quite an old film, but a PK deficiency picture. And I've included this because sometimes there's a lot of registrars studying these workshops, and this is the sort of case that they may well give them in their exams, because we see it so irregularly or so rarely. So this case has had the spleen taken out, and this picture to an experienced morphologist says, if you've got no history, this is a case of PK deficiency post-splenectomy. So here we see the Hal-Jolly body, the last nuclear remnant of the red cell. Here we see, I think there's quite a few Pappenheimer bodies around. So these cells, which are iron granules, little tiny bits of usually in groups, but there's not that many in groups in this one here. That might be a group up there. There's a few Pappenheimer bodies here. And then there are features, if you look carefully, you may see features of the post-splenectomy. So you'll see spherocytes, not in this image, but you could see target cells. There's a prickle cell there, or you could see acanthocytes. You're going to ask me the difference between the two. Look at my red cell workshop, and you'll see the difference. They're quite significant when you look at the red cell images under the electron microscopic picture. Okay, so this is a classical picture of a PK deficiency post-splenectomy, mainly put in here for registrars, because they seem to always give them a picture like this in their morphology exam. So now going back to the very young child, talking about a microangiopathic hemolytic anemia. The most classical example is a child that has got hemolytic uremic syndrome. So hemolytic uremic syndrome occurs most commonly in infancy and early childhood, and it's inherited by the infection with the E. coli bacteria strain 0157. So this bacterium produces a sugar toxin, which is a verocytotoxin. This toxin is attracted to the vascular endothelium, especially the endothelium lining the glomeruli of the kidney, and it induces severe glomerulonephritis, leading to a microangiopathic blood picture. So what you're going to see in this blood film, you're going to see the presence of schistocytes, polychromasia, and thrombocytopenia. Just going back to that previous slide. So schistocytes, and I've often been called the schistocyte lady because schistocytes are not fragmented cells. Schistocytes comes from the Greek word ski, S-K-I-S-S, which means to rip. So if you've got a microangiopathic hemolytic anemia, and just translate this for you, micro, small, angio, vessel, pathic disease. So if you've got narrowed vessels in the kidney, for example, and your red cells are passing through the glomeruli, which is narrowed, they're going to get ripped as they pass through. It's like and I say this to my trainees at Prince of Wales, it's like dragging you across a pebbled street. So in some areas of Europe where there's little narrow pathways with pebbled streets, if I dragged you across that without your jeans on, you would get shredded skin coming off. So that's what's happening to your red cells. They're shredded, and they're not fragments. They've been produced by a microangiopathic process, which in turn gives you an increase in reticulocytes to compensate for the red cell destruction, and thrombocytopenia because the platelets come along the damaged glomeruli and get trapped in the irregularities of the epithelial cells lining the glomeruli, so the platelet count drops. So please, people who have studied my workshops, don't ever refer to schistocytes as fragments, because that is incorrect. And if you look at the ICSH document, they'll give you 11, I think, synonyms for the term schistocyte, and explain in no uncertain terms that you use the term schistocyte and not any other term. So this is a nice example of a child. I think this was a little 2-year-old child that had come in with anemia. It was quite septic. So if it's a 2-year-old, one would normally expect more lymphocytes in the 2-year-old's blood film. So they're it's an overwhelming, I'm trying to portray an overwhelming number of neutrophils, which are what we call hypergranular, so a feature of sepsis. And then we look at the red cells. Probably the cells at the top of this field are more exact. I should have lowered my, changed the position of my slide before I took this photo, but this is a classical schistocyte. It's been ripped, it's got pointed ends. This one here and this one here. So some of these are a bit less classical, but they're definitely red cells which have been ripped. And this is proving that they've got a septic infection. They actually had an E. coli infection. So this is a classical picture of hemolytic uremic syndrome in a 2-year-old. This is another example. This is a child who had an ASD and a VSD repaired. This is before repaired, being repaired, and had a very microangiopathic hemolytic picture. Look at this one here. I am a schistocyte. Here and here, they're everywhere. Now, in heart valve hemolysis, you will find that the platelet count is normal. Because if you've got an ASD or a VSD, in other words, a hole in the valve, the red cells are pushed through that hole with the force of the flow going through the heart, but the hole is smaller than the red cells. So the red cells will be sheared off, giving you schistocytes. But the platelets, which are much smaller than the diameter of the hole in the valve, they will go straight through. So heart valve hemolysis is the only disorder which is microangiopathic with a normal platelet count. So now Diamond-Blackfan anemia. I did explain it to you, but it is actually quite a rare disorder. So it's a congenital disorder and pure red cell aplasia, diagnosed in children usually less than 1 year of age. They do get abnormal facial abnormalities, so they get craniofacial and abnormalities such as they get a more flat nasal bridge, a wide set eyes, and a thick upper lip, as well as they can be deaf and have a short stature. The hemoglobin level would have a mean value of about 70 grams per litre, but it can go down even lower, as low as 26 grams per litre. And interestingly enough, when the child is in the microcytic hypochromic age group with a normal RDW, they will be macrocytic. So that MCV will be probably the first flag that the pediatrician will pick up and say, oh, so this is a 2-year-old with an MCV of 100 or over 100, for example. They have a reticulocytopenia. So not many reticulocytes, so very low reticulocyte count. And the bone marrow shows erythroid hypoplasia. The myeloid cells and the megakaryocytes are normal in number, while the lymphocytes may be increased. And this is just an interesting case. This is a 2-year-old, and I noted had Diamond-Blackfan anemia, so I thought, oh, look at the MCV. That's very high. I put a small lymphocyte nucleus again to remind you that 7 microns in diameter, which is the size of a normal red cell. So you can see that these red cells are very clearly macrocytic, and it's quite anemic. So just a bit of a fun image to show you Diamond-Blackfan anemia in a 2-year-old. So now congenital sideroblastic anemia. This presents in early childhood, mostly in males, and it's characterized by a dimorphic blood picture. The bone marrow is hypercellular with erythroid hyperplasia. Some of the erythroblasts show microerythroblastic maturation, as well as defective hemoglobinization with ragged and vacuolated cytoplasm. Now, the Pearl's Prussian blue stain can be used to demonstrate the ringed sideroblasts in the bone marrow of such a patient. So these ring sideroblasts represent the presence of perinuclear mitochondria containing large deposits of inorganic iron. And heme production is impaired and there is ineffective erythropoiesis. So the iron stores are increased. So this is a blood film of a slightly older child who has got congenital sideroblastic anemia. And I think this is quite fascinating because this is very rare. And this child is actually, I think he was just old enough to have his spleen taken out. So there are Hal Jolly bodies in this film. But basically, I want you to see that I said it's a dimorphic film with hyperchromic microcytic red cells. So you can see the two populations of red cells. I think they may have had their spleen out. That may be a Hal Jolly body. But you can only have a single Hal Jolly body in a red cell. So there are Pappenheimer bodies, which are iron granules, which I'm pointing to, which usually appear in groups, and they're much smaller. So that's a beautiful slide of congenital sideroblastic anemia. Again, very rare. I think I've cheated a little bit because I've just shown you the Pearl Prussian blue stain of someone who had refractory anemia with ring sideroblasts, and it was an adult. And I spoke to you about that last time. So these are the iron granules sitting in the mitochondria. Back to that slide, sitting in the mitochondria. Okay. So we're now going to go to the leukocyte differential and the features that you see in the white cells. These are the reference ranges. And by the way, any of you who want to take these reference ranges for yourself, did say in the beginning of all my workshops, there's a copyright, but these reference ranges are certainly, you may take the reference ranges and put them into your computer if you would like to do that. So again, very busy ranges, and quite frankly, I don't remember them all, but if I look at the next slide, I'll show you what's important to remember. And this is much easier than the red cell ranges. So when the baby's born, as I said to you, the baby, if it's a vaginal birth, a normal birth, the baby has to work just as hard as the mother. So it's going to have a high white cell count. We look here, it can go from 4.4 to, this is for the neutrophils. So basically, it's had to work really hard. So it's going to have an absolute neutrophilia. Remember, if it's born by cesarean section, gently lifted out, the white cell count will be lower and the number of lymphocytes will be much higher than this. This is neutrophils to lymphocytes. Now that high neutrophil count persists probably for a couple of weeks and then drops. So the neutrophils, after that period, the neutrophil count drops, and we have more lymphocytes than neutrophils from about 2 weeks on to the first 4 weeks, for the first 4 years, I beg your pardon, of life. So after 2 weeks, we find the inverse ratio, more lymphocytes than neutrophils, and that range persists for the first 4 years of life. So again, you need to look very carefully at the age of your child and then judge whether that differential is normal for that age. So now, leukocyte disorders in the neonate. There's a whole lot of disorders, which I'll go through with you. So there's congenital leukemia. This can happen sometimes in Down syndrome, which is trisomy 21. So this is the leukemia which appears on day 1 in the neonate. It's called the congenital leukemia. It's different from the TAM, the transient abnormal myelopoiesis, if you remember. And then there's neutropenia. So neutropenia can be associated with maternal neutropenia, infantile agranulocytosis, chronic benign granulocytopenia, and cyclic neutropenia. So this is interesting that this is a cyclic process where it's neutropenic at one period of time and then it's not the next, and they grow out of that fairly quickly. Then there's lymphopenia. There's infection, so it could be bacterial. It could be NEC, which is necrotizing enterocolitis. It could be viral. It could be a leukemoid reaction that you're looking at, and that would be a case when the child has been given granulocyte, colony-stimulating factor, cytokines, or granulocyte macrophage, colony-stimulating factor. But this would only be given to a child who's perhaps having a transplant and needs to have cytokines to boost up the white cell count before they're giving chemotherapy. Then there's the congenital anomalies of the leukocytes. And you should consider all of these examples. Pyruvate anomaly, May-Hegland anomaly, Chediak-Higashi Syndrome, mucopolysaccharidosis, Hurler syndrome. And I just might mention at this point that if you're unaware, there is a book that I have written, and it's called Microscopic Hematology, a practical guide for the laboratory, and that's available from my website, and all of these rare disorders are listed in my textbook with some really nice images. Probably not as nice as you'll see on your PowerPoint presentation here. So let's look at sepsis in the neonate. So diagnosis of neonatal sepsis is one of the most difficult tasks in clinical medicine. Septicemia in the neonate has a high mortality rate despite the use of antibiotics. Please never forget that, it's very important. So the importance of counting every myeloid precursor in this age group, including band forms. I cannot overestimate that importance. Don't say that there's a left shift in the myeloid line when you're looking at a neonate. You need to go do a formalized differential, counting every myeloid precursor. And a ratio of band forms to total neutrophils of 0.2 or higher is suggestive of sepsis. Now the QAP, RCPA QAP have a definition of a band form somewhere in their documentation, and it reads as such: a band form has no nuclear segmentation. The width of the nucleus at any constriction point is no less than 1/3 of the width at its widest point. So we all need to be uniform in the way we actually count band forms. So that's the criteria. If we follow that criteria, we'll all be synonymous with the number of bands that we count. But please don't ever say a left shift on a neonate. You must give them a full differential. Now, just to talk about toxic granulation. So sepsis and toxic granulation. So toxic granulation in isolation is not specific for sepsis. and it can be seen in other conditions. So bear this in mind. It can be seen in older granulation or older Riley anomaly, which is a mucopolysaccharidosis. Example of that is in my book as well. It can be seen in Chediak-Higashi anomaly. This is a feature where you can get, basically, you get the primary and the secondary granules fusing together, and they're not basically working properly because they're big, large, lazy granules. So children with Chediak-Higashi can get bacterial infection, but you need to recognize that it's actually not toxic granulation. It's the fusion of the two primary and secondary granules. You get toxic or get granulation in cytokine therapy, so you get an increase in the primary granules in post GCSF, granulocytic colony stimulating factor. You can get it in Crohn's disease and ulcerative colitis, according to the textbooks. I must admit, I think that's pretty rare. You can get it in Kawasaki disease. You can get increased primary granules in Kawasaki disease. So the message here is, and if you look at the RCPA QAP, if you look at their workshops, and if you also look at the ICSH document, you'll see that we do not use the term toxic granulation now. We use the term hypergranulated neutrophils. And that's because you can get hypergranulated neutrophils in Kawasaki disease in post-GCSF therapy. So that's the very reason why we say hypergranulated neutrophils. So this is a case of a patient who's got sepsis, true sepsis. You can see there's a bit of a left shift. You can see the evacuation. You can see the increase in the primary granules. And that's a classical case of sepsis. I'm going to show you now Kawasaki disease and a bit of a history on Kawasaki disease, because this is, again, one of my pet hobby horses, Kawasaki disease, because we need to be focused on diagnosing this. And if you don't work with children, pediatrics, you may not have even heard of Kawasaki disease. So it was first described by a pediatric hematologist who was obviously Japanese in 1974. And it's an acute febrile vasculitis. It affects children from 2 months to 5 years or more of age. And it's characterized by classical features, clinical features, which are linked to the blood changes, and in conjunction with those classical features that I'm going to just enumerate here for you, the diagnosis of Kawasaki is made. But you cannot diagnose Kawasaki from the blood film alone. So be careful about that. So they get non-exudative conjunctivitis. They get erythematous lips and a strawberry red tongue. They get erythematous and edematous hands and feet, and an erythematous truncal rash and a desquamating perineal rash. So looking at the blood film, what do we see? Depending on the age, it's either normochromic, normocytic anemia. Probably it would be slightly older group. It'll have an elevated ESR. It will have an absolute neutrophilia, which won't be in keeping for the age. You'll see neutrophil granulation and vacuolation. And then one thing that we can't explain is you'll see neutrophil cytoplasmic swelling. So look very carefully at the edges of the cytoplasm and see how it's swollen. And sometimes it may be swollen to the degree where there's not enough granules to fill that swollen area. So you might get even like a pale blue bulge on the area of the neutrophil. And it is a feature only of Kawasaki, but we can't explain the reason. And they have a thrombocytosis. So there's all the things that if you're working in children, you must be aware of the features you see in Kawasaki disease. So what's the treatment? So it's diagnosed. I just want to see what my next slide is. Okay. So Kawasaki, when we see all those features, sometimes they're given us a clinical note that says query Kawasaki disease, but often we're not. So if we see all those features, we would ring up the consultant looking after the child. Very important to do that because we don't want this to get missed because these children get aneurysms in later life, even in sort of early adult life, they get aneurysms. So we don't know the cause of it, so it's important to link the fact that you see these changes. And we would mention what we see on the blood film, and then we would have a code. We do have a code that says, note features of cytoplasmic swelling present, a feature seen in Kawasaki disease. That's a code which is one of New South Wales Health codes. So that should be used, and you should pick up the phone and talk to the consultant looking after that child. So this is another thing that you need to think about. What's the treatment? They give them intravenous immunoglobulin or Intragam, and it's very heavy doses. They give them 2 grams per kilo body weight. So if this is not recognized and treated immediately, the Kawasaki disease can lead to coronary aneurysms in adulthood, early adulthood, as I just explained to you. Now, when you give them, just going back, when you give them this Intragam with this massive dose, you might find that a week or 10 days later, this same child comes in with a autoimmune hemolytic anemia. And if you've been very vigilant and done what I've said in some of my previous workshops, if you put the clinical notes into the patient notes, you'll be able to look at your clinical notes immediately and say, oh yes, that was that child that came in 10 days ago with Kawasaki, been treated with Intragam and got this massive autoimmune hemolytic anemia on the film. That will explain it. So here's a nice example. These 2 cells, these 2 neutrophils especially, this one here has got these 2 bulges here and here. This is what we call cytoplasmic swelling. And you can see that the granulation in these neutrophils is increased. This one's not so good, but it's still got a hint of being cytoplasmic swelling there. So just talking now about leukomoid reactions and what cytokines do. This is a case of a patient being given granulocyte, colony stimulating factor. You get a leukomoid reaction. And a leukomoid reaction, it's quite an old-fashioned term, but it's one in which there's an increase in the myeloid line, resulting in a blood film that actually can resemble looking like a leukemia, but you get quite a significant left shift in the myeloid line. So there's an increase in immature granulocytes. So you get, yes, you can get blasts, promyelocytes, myelocytes, metamyelocytes, band forms, and mature neutrophils. So when I say blasts, pardon me, if you have a history of the patient on GCSF, then that's good. If you don't have a history of the patient being on GCSF, one needs to put a comment underneath your film comments, query on GCSF therapy. Can we just take a break, please? Sorry, I just have to have a sip of water. Okay, so that's GCSF. So, and GM, CSF, but they tend to use it less often. M standing for macrophage. It is associated with increase in primary granulation, as I've just explained, and it's important to recognize these changes are associated with GCSF and look to be septicemia, but they're in fact not septicemia. So here's a nice slide of GCSF therapy. It's a leukemoid reaction. You can see there's slight left shift in the myeloid line, and certainly the neutrophils are filled with primary granules. So we call this hypergranulated neutrophils. Now, this is a very long session, and I'm not going to reiterate some of the lectures that have already been given. So we do refer in the myeloproliferative myelodysplastic PowerPoint presentation, we talk about the features that you see, the WHO classification of the myeloproliferative neoplasms. So I'm not going to repeat that, but we talk, I think, quite at length with juvenile myelomonocytic leukemia. And also we talked about TAM, transient abnormal myelopoiesis. So we referred to the patients who have got Down syndrome, and that was in the WHO classification of acute leukemia lecture. So we're not going to reiterate that particular lecture, but this is the interesting patient who's got the transient abnormal myelopoiesis, if you remember, with an increase in blast cells in the peripheral blood, and we have to make a decision: is this congenital leukemia or is this TAM? And remember that for the first 3 months of life, if it is truly TAM, then the blast cells disappear. And so that's why we call it transient abnormal myelopoiesis. So you can look back onto that lecture, because that's a fascinating lecture. So now, still on the in the line of bacterial infection, Bordetella pertussis, which is whooping cough. So the persistent lymphocytosis present in the blood film of a patient with Bordetella pertussis is due to a lymphocyte promoting factor produced by this bacteria. And the interesting thing is that it is sepsis, it's a bacterial infection, but is produced by a bacterium. So this factor inhibits, this is the factor that's produced by the bacteria, and it inhibits the migration from the blood. It inhibits, the lymphocyte migration from the blood to the lymphoid tissues. So Bordetella pertussis, it's whooping cough. It's a highly infectious disease occurring primarily in infants younger than 2 years of age. It results from inhaling droplets contaminated with Bordetella pertussis or aerosol. The blood film shows a marked increase in the number of T lymphocytes, and the total leukocyte count ranges from 15 to 50 by 10 to the 9th per liter, and you can have up to 70 to 90% lymphocytes. So if you're looking at a blood film, remember 2 years of age, you will get more lymphocytes than neutrophils, that's the range. But when you see an increase in the lymphocytes in that age group, it should trigger your brain to think that's not normal. I would think to myself, so what are the disorders in a 2-year-old which would have a high lymphocyte count? Obviously, it's not CLL because that's an adult disorder. It could be a viral infection, so I may start to look for reactive lymphocytes. but I'd also look very carefully at the morphology of the lymphocytes with that high white cell count in that age group. So not a very good image of the red cells, but I'm concentrating on the white cells. So this is a case where I'm tried to portray for you that what you get in the Bordetella pertussis infection is you get these cleaved lymphoid lymphocyte nuclei. So when you're looking at these lymphocytes, you can see the cleft here in this cell here. You can see this one's cleaved as well, and this one's cleaved as well. So that's what you look for. And I can't answer the question if you're going to ask me what percentage. I'm going to concentrate on a few things, on the age, on the absolute count, and then how many of these lymphocytes have cleaved nuclei. It's up to the clinician, but again, a bit like the Kawasaki disease, when you see this on the blood film, you should write as your underneath your report, your film report, lymphocytosis with cleaved lymphocytes present, a feature seen in Bordetella pertussis. There's also a code in the New South Wales codes. So you ring up again the consultant and let them know, because if this child is in a ward and coughing and aerosols going into the atmosphere, it's highly infectious. So this is very important for us to be mindful. That's why I say so important to look at pediatric blood films very, very carefully and have all this knowledge in your head. And by re-looking at all these workshops that I'm giving you, you'll be able to have all that in your head and not miss any of these very important features on the blood film, because you're helping the clinician to make a diagnosis of what's going on. Just going back to that to say one more thing. So I understand, I think it's still the current treatment to give these patients erythromycin. And so you might see a reduction in the number of cleaved lymphocytes. But so important to let them know about that lymphocyte count and the presence of cleaved lymphocytes. Now we're going to talk about a lymphocytosis with a true viral infection. This is infectious mononucleosis, which I think many of us wouldn't have too much trouble diagnosing on the film. So this is an infection caused by the Epstein-Barr virus occurring in teenagers and young adults. The blood film shows a proliferation of viral infected B lymphocytes with a population of reactive T lymphocytes. The reactive T lymphocytes have round or irregularly shaped nuclei with abundant flowing basophilic cytoplasm. Thrombocytopenia is a common feature in infectious mononucleosis, as it is in any viral infection. Any viral infection will probably have a mild thrombocytopenia. Infectious mononucleosis is heterophile antibody positive. Other viral induced lymphoproliferative disorders are heterophile antibody negative. So it may be difficult. You may get difficulty in making a diagnosis of infectious mononucleosis in a child under 2 years of age, as their immune system is still not developed. And over time, I have noted that. So when I see a child with reactive lymphocytes, and I think it could be infectious mononucleosis, under 2, I'm not going to do a monospot test. I would suggest the Epstein-Barr virus titer, because over the years, I'm finding that it just doesn't work in children up to 2. And as I said here, a definitive diagnosis using viral serology must be used in such cases. So this was a 3-year-old and these are reactive lymphocytes. So they've got the chromatin pattern. No, it's fairly normal, but they've got really basophilic cytoplasm, which is not showing up so well here. So the basophilic cytoplasm is often sort of have a rolled border, which is darker around the edge. And I might have said in some of my talks, there's possibility that it might have a nucleolus in the nucleus, but that's probably very unusual. But this is a classic picture of a little child who is actually 3 years old. Actually was the son of one of the workers, one of the scientists in hematology, and the monospot came up positive with him as he was 3 years of age. So now I would be giving you, if I hadn't done the topic, the WHO classification of acute leukemias, and I hadn't talked about the lymphoblasts, lymphoblastic leukemia / lymphoma, I'd be including a B cell ALL in this particular section. So if you go back to that topic and look carefully at the lymphoblasts, it's clearly shows you the morphological features of the lymphoblasts. And I've also, when I do lymphocytes, which is actually the next lecture coming up, I'm going to show you the difference between reactive and neoplastic lymphocytes. So remember, ALL, acute lymphoblastic leukemia, is the most common leukemia found in children. In children under 6 years of age, it has a very good response to treatment. I may not have told you this, but the treatment goes for about 2 years. They're often put on different trials. They have repeated bone marrows and CSFs collected over that 2-year period. And they have a really good response to treatment. I can remember many years ago, would be about 75% of children went into remission, but nowadays we're talking 2021, about 94% of children after their 2-year regime of treatment go into remission and never relapse. The older they are, so the prognosis is not so good. So under 6, it's a very good prognosis, and over 6, not such a good prognosis. And of course, if it's a T cell ALL, they don't have such a good prognosis as well. So you've got a really good lecture on all of that. Now I'm going to show you some of the really rare. As somebody used to give a topic at the RCPA QAP workshops, the rare, bizarre, and beautiful. This is congenital anomalies of white cells, and this is why you really have to look carefully. That's why I'm emphasizing this. So this is a storage disorder, can be seen in neonates, and it's sialic acid storage disease. It's a rare autosomal recessive neurodegenerative disorder resulting from a block in sialic acid release from the cell lysosomes. And you get accumulation of sialic acid in many cells, including the lymphocytes and some of the other body fluids, and it leads to cytoplasmic vacuolation. So it's diagnosed by the presence of increased amounts of sialic acid in also, as I said, urine and of course blood in the lymphocytes in the blood. And there are 2 forms of this sialic acid storage disease. There's the aggressive form, known as the infantile sialic acid storage disease, and the less aggressive form, known as SALA. And SALA is the area in Finland where this was first diagnosed. So the more aggressive form is characterized by these coarse facial features. They lack skin pigmentation. They have a hepatosplenomegaly and they're anemic. And this progresses to fluid retention, ascites, heart failure, and early death. Sala disease has two additional features. They get mental retardation and cerebellar ataxia. So the features of Sala stop progressing after early childhood. And this is the first case of Sala disease, Sala acid storage disease that we had in our laboratory. And this is why, again, I reiterate, these are lymphocytes, but look at the cytoplasm. It's vacuolated. You know, you can get vacuolated cytoplasm in neutrophils. Even in old blood, you can get vacuolated cytoplasm. And you would know that it was a feature of old blood. So the blood was sitting around on the bench before it was processed the next day, but not in lymphocytes. So you do need to look very carefully, be very vigilant. And I'll tell you about this child. This was a 6 weeks old child that the mother brought in. It was apparently jaundiced at birth. And she said she noticed that even still at 6 weeks, there was a bit of jaundice in the whites of the eyes. So she brought it in. And it seems that every child that comes into the accident and emergency or the pediatric accident and emergency department, they have a full blood count done. So it's really amazing hospital here at Prince of Wales, and they're so thorough with the children. So every child has a full blood count done. And if that wasn't done, we wouldn't have picked this. So we looked at this film from field to field. We saw these lymphocytes with vacuolated cytoplasm, and that was sent away. The blood was sent away to a laboratory in South Australia, in Adelaide, where they test for these various disorders. And it came back as being sialic acid storage disease. So I think it's the only case we've seen. So now you've all got an example of that. Then there's Hurler syndrome. That's another interesting way that we acquired this Hurler syndrome. I'll just explain it to you first. It's a mucopolysaccharidosis storage disorder. It's characterized by the presence of lymphocytes whose cytoplasm contains clear vacuoles, but in this case filled with coarse metachromatic granules of mucopolysaccharide. And these lymphocytes have been described by a pediatrician known as Gasser, and they're often referred to as being Gasser lymphocytes. Now this is taken under oil immersion, so it's 1,000 times magnification. But I think you will believe me if I say, if you don't look very carefully at these lymphocytes, which you'd be looking at on times 40, you would be missing these cells. These are lymphocytes of Hurler syndrome, and these, if you look very carefully, you can see they're actually in a vacuole, each granule, and it's mucopolysaccharide in each granule. And this was discovered by accident as well, because one of our registrars in hematology, her husband was a surgical registrar, and he rang her about 5 o'clock one afternoon to say, I've just got a child in theatre who's got Hurler syndrome. Would you like some blood? I had no idea I was still at work, and I said, yes, we would like some blood, please. And that's how we saw our first case of Hurler syndrome. And now we've had several cases from the Children's Hospital, and they transplant these children and cure them. So that's Hurler syndrome. The Meheglin anomaly. Meheglin anomaly is a congenital anomaly characterized by the presence of basophilic inclusions, or RNA, ribonucleic acid, within the cytoplasm of neutrophils. And these inclusions resemble Döhler bodies. But the only thing that is different about these films is that they're severely thrombocytopenic. They have giant platelets, which occur in approximately about 1/3 of cases of Meheglin anomaly. So here we've got a beautiful example. These platelets are in fact large. Some may be giant, and just to remind you, a large platelet is smaller than the red cell, and a giant platelet, really that's not quite giant. Giant platelets are larger than the red cell. If you look very carefully at this film, and you sometimes may have to go into the slightly thicker part of the film, you will see, if you're trying to work it out, obviously there's thrombocytopenic, large platelets. Look at the cytoplasm of the neutrophils and you'll see these bodies which look like Döhler bodies in the cytoplasm. And this is pathognomonic for May-Hegland anomaly. Okay. Chediak-Higashi anomaly. It's a congenital anomaly characterized by the presence of giant granules in the cytoplasm of neutrophils and lymphocytes. These granules result from the fusion of primary and secondary granules. So Chediak-Higashi granules are not attracted to the phagocytic vacuole during infection. Hence, bactericidal activity is impaired. So when you think of the primary and the secondary granules fusing, you get these big granules. They could be mistaken for hypergranulonate neutrophils, but I hope not. But the granules are big, fat, lazy granules. They're the granules that contain the lytic enzymes that kill the bacteria. But if they don't move to the side, to the edge of the neutrophils to kill the bacteria, because they're fat and lazy, the patients get impaired bactericidal activity. So some of you might know this picture. This is actually on the front cover of my second textbook, I think. And this is the bone marrow of a patient with Chediak-Higashi anomaly. And this was a patient from another country, actually, from Indonesia. And somebody lent me the bone marrow of this patient's film. So it's a beautiful film. You can see these great big lazy granules. They're not going to move towards that phagocytic vacuole. So we see this in all nationalities. And again, they transplant these patients and give them a new life. So that's the end of the white cell section, and I think we've covered just about all the rare and bizarre disorders. But remember, look very carefully, especially at your lymphocyte nuclei, or not so much the nuclei, but well, in the neonate, yes, of course, remember the first slide I showed you, but also look at the very carefully at the cytoplasm. And note that vacuolated cytoplasm can be a feature of a neutrophil, but not a lymphocyte. Okay, so moving on to platelets. You can see here the platelet count. Our normal platelet count for an adult is 150 to 400 by 10 to the 9th per liter. But you can see here between 3 and 6 months, you can see the platelet count is actually quite high. So I'm just thinking, because when we did the reference ranges, I'd seen lots of pediatric films, but I hadn't done in depth the ranges and the number that we had. And we were actually an adult hematology laboratory. And when we saw a film with a platelet count like this, we would comment and say, notes thrombocytosis, query cause. And we did that for a while. I'm not too sure for how long, while we were waiting to actually finish our ranges and unfortunately not publish the article, but establish good ranges, which we were using in our computer now. And after we'd done this, they were put forward to the pediatricians, private and public, And they said yes. When I asked the question, is this what you would expect to find in children, these reference ranges? They said yes. So we finally had to stop saying known thrombocytosis query cause. So they're the reference ranges for platelets. And again, don't forget, you can take these ranges and put them into your computer. Because I'm a natal authority person, and I'm also got a few other credentials, I'm sure these are very safe, even though they're not being published. They're Australian figures. When you look at textbooks and you look at Nathan and Oski, it's an American textbook. I don't think you'll find them in Dacey and Lewis, Practical Hematology, but if you do, it's an English textbook. So these are Australian ranges. So feel free to use them should you wish to. So thrombocytopenia in the neonate. It's two types of thrombocytopenia. There's destructive thrombocytopenia and impaired or ineffective platelet production. So let's look at the causes of these different types. So destructive thrombocytopenia. You would think immediately of immune thrombocytopenic purpura, which we will talk about, which is probably the most common. And then there's a drug-induced thrombocytopenia, infection-induced thrombocytopenia, post-transfusion purpura, autoimmune or lymphoproliferative disorders associated with the thrombocytopenia, neonatal immune thrombocytopenia, allergy and anaphylaxis, and post-transplant thrombocytopenia. So there's a non-immune, so we think of chronic microangiopathic hemolytic anemia and thrombocytopenia, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and congenital or acquired heart disease. By the way, I didn't mention thrombotic thrombocytopenic purpura or TTP in this particular workshop, but the blood film looks the same as the hemolytic uremic syndrome with the schistocytes. So then there's the features that are specific to the neonate, so you should consider phototherapy, persistent aspiration syndromes, persistent pulmonary hypertension, rhesus alloimmunization, and post-exchange transfusion. So then the next group, impaired or ineffective platelet production, so primary hematological processes. Think of TAR syndrome. This is a very rare disorder of which we've had several cases, and they transplant these patients. It stands for thrombocytopenia with an absent radius. Then there's other congenital thrombocytopenias with megakaryocytic hypoplasia, Fanconi anemia, Bernard-Soulier syndrome, Meheglin anomaly, Wiskott-Aldrich syndrome, and Mediterranean thrombocytopenia. I think this is so rare that I've not really seen a true case of this, but it does appear in the textbooks. And then there's the acquired, impaired or ineffective thrombocytopenia. So think of aplastic anemia, bone marrow infiltration. Think of the neuroblastoma, for example, that can be present in utero, and drug or radiation induced. And then there's sequestration, so hypersplenism. So ITP, immune thrombocytopenic purpura. You can see this quite frequently, so you need to understand this process and how you should look at the blood film very specifically for specific features on this film. So one of the most frequently seen examples of destructive thrombocytopenia is ITP. A typical history will be bruising and petechiae appearing suddenly in a child who is in otherwise excellent health. The peak age for the presentation of ITP is from 2 to 4 years. And when I say in excellent health, all the other parameters are normal except for the very severely low platelet count. In childhood ITP, males and females are affected with equal frequency, in contrast to adult ITP, in which females predominate by a 3-to-1 ratio. Often there's a history of a viral illness prior to presentation, and that's what the doctor is going to be inquiring, because the child comes in with this petechial rash, and all the other parameters are normal except this very low platelet count. So they're going to ask the parents, has your child had a recent viral infection? In the majority of children, ITP is an acute self-limiting disease, resolving within 6 months, whether or not therapy is given. One of the 2 medical therapeutic options are chosen. Corticosteroids, however, most doctors don't want to give children steroids, or intravenous immunoglobulin, or IgG, and this is the choice of treatment. Either will increase the platelet count in the majority of patients and presumably decrease the risk of serious hemorrhage. So they'll give them intragam to make that platelet count come up, because the platelet count is usually less than 10 by 10 to the 9th per liter. So if you've got a little 2-year-old who won't stop jumping around or falling off its tricycle with a platelet count of less than 10, it can be quite dangerous. So they tend to do the treatment this way. There are some doctors who will do a bone marrow, and they're looking for the number of megakaryocytes in the bone marrow. So if they see plentiful megakaryocytes in the marrow, then they can assume that it's peripheral destruction that's causing the thrombocytopenia. But most doctors tend not to choose to do a marrow for this, because basically just giving them intragam will make their platelet count come up fairly quickly. Now, if I were ever to find the most amazing image to show you a reactive lymphocyte, this is the one. So this is, I better mention this is not atypical. So the ICSH document, and by the way, anybody that's looking at these workshops, please email me if you want the ICSH document on the standardization and classification of blood cells, because it gives you very strict instructions. You do not call these atypical. The term is reactive, and you can pick them easily because they've got, classically like this, they've got this very basophilic cytoplasm with often these condensed borders which look to be darker staining, and the platelet count will be very low. So this is the term not atypical, never atypical. It's a bit like schistocytes, never fragments. Oh, I'm going to go back to that slide. So if you see this in your film, and you're looking at a young child with a very low platelet count, say less than 10, there are certain features that you should look for on the blood film. Firstly, you should look and scan the film to see if you see reactive lymphocytes. And even if you only see an occasional one, you should mention it, because it's very helpful. As I've said, it's a feature of a viral infection, so it's helpful for the doctor looking after the patient. Also look for large platelets, and you can see there's no platelets here, but if you look from field to field and you see large platelets, you need to mention the fact that there are large platelets there. So large platelets are young platelets, and they're large because they're immature, and it means that the marrow is trying to compensate for the lack of platelets. So however few you see of the reactive lymphocyte and the large or even giant platelet, report it because it is very significant. The clinician will really appreciate your reporting it. Okay, so now Bernard-Soulier syndrome. It's inherited as an autosomal dominant disorder, and it's characterized by thrombocytopenia. The platelet count is usually around 50 to 60. That's the same sort of level that you get for May-Heglen anomaly as well. Both of them are much the same platelet level with large and giant platelets. Only that in the May-Heglen, you're going to look for the Döhler-like bodies in the cytoplasm of the neutrophils. So in Bernard-Soulier, they have giant platelets, and some of the cells, some of the lymphocytes are small. I think that's a bit of trivia. I wouldn't worry too much about that. So the platelets demonstrate in Bernard-Soulier a quantitative defect in the glycoprotein 1b59 complex, which is the platelet within the platelet membrane. The Bernard-Soulier platelets demonstrate normal aggregation in the presence of adenosine diphosphate or ADP, epinephrine or adrenaline, collagen, and arachidonic acid, but they don't aggregate in the presence of Erythroblastosis. These tests are done in very specialized laboratories where they do platelet function tests. So you're basically not going to be able to diagnose Bernard-Soulier from other macrothrombocytopenia, sort of thrombocytopenia disorders, until you do these platelet function tests. And just the fact that the diagnostic features, they don't aggregate with Erythroblastosis. This is a case of Bernard-Soulier. Trying to show you it's almost a giant platelet. Trying to show you that it's almost larger than the lymphocyte nucleus. So now Wiskott-Aldrich Syndrome. This is an X-linked recessive disorder. It's characterized by thrombocytopenia, but they have small platelets and they have a slightly reduced survival time. So the thrombocytosis is ineffective, while the megakaryocyte numbers range from normal to high. Sorry, that's thrombopoiesis. Thrombopoiesis is ineffective, while the megakaryocytes range from normal to high. It's an interesting disorder. So it's associated with an immunodeficiency, and there's an inability to produce antibodies that makes these children susceptible to both bacterial and viral infections. So they can get warts and herpes. That's a fairly common feature. They get eczema, probably less commonly, but they can get eczema, and they have a positive hemolytic anemia can occur. So DAT positive, direct antiglobulin test positive hemolytic anemia. So this is the blood film, and you might think, oh, that's just nothing very interesting. But look at the size of the platelets. They're very small. Now if you look at your mean platelet volume and your platelet distribution width, they'll be abnormal. Your mean platelet volume especially is a significant feature, and a low MPV, especially on a Sysmex analyzer, is a classical feature of Wiskott-Aldrich syndrome. We don't see it so much on the Beckman-Coulter. I have to say that because I'm explaining to you how you make a diagnosis of this disorder. These children are given bone marrow transplants, and That's the mechanism for return to normal. But look at your mean platelet volume. And if you're looking at a Sysmex result, you'll probably find it's normal. But if you're looking at the other Beckman-Coulter, there's a lot of variation in the mean platelet volume. So now thrombocytosis, primary thrombocytosis. We don't see this occurring very often in children, but myeloproliferative syndromes are associated with a thrombocytosis. In the myeloproliferative syndromes, you'll see variation in the platelet size as well, large and giant platelets. Then secondary polycythemia and idiopathic sideroblastic anemia, you may see a thrombocytosis. I've listed now the secondary or the reactive thrombocytosis. So the diseases where you see this is inflammatory diseases, acute infections, acute rheumatic fever, juvenile rheumatoid arthritis, ulcerative colitis, and regional enteritis. So iron deficiency is associated with the thrombocytosis. You may not have noticed it, but look at some of your cases of quite severe iron deficiency and you'll see a thrombocytosis. Vitamin E deficiency, very rare now. We don't really get that now occurring. And chronic hemolytic anemia and in some of the hemoglobinopathies. Then some neoplasms will have associated thrombocytosis, so lymphomas, neuroblastoma, and other childhood solid tumors. Ewing sarcoma, for example, is another childhood solid tumor. And of course, our neuroblastoma is already mentioned. Okay. So secondary or reactive thrombocytosis. This is by far the most common cause of a high platelet count in children. It is reactive. Okay, it's a reactive thrombocytosis. It may be due to inflammatory disease, think of infection, a rheumatoid condition, so juvenile rheumatoid arthritis may be associated with a thrombocytosis, and Kawasaki disease, which we've already mentioned, is associated with the thrombocytosis. So in these situations, the thrombocytosis usually parallels the degree of activity of the underlying condition. And here's an example of this child did actually have juvenile rheumatoid arthritis. And this is an image taken under 100 oils. So you can see, normally if you're estimating an ESR, for example, on a blood film, you would estimate it on times 10 magnification. But this is on 6 times 1,000. And you can still see in the area where you should expect to see the red cells lying side by side, you can see the red cells are tending to be in chain. So this ESR was very high. It was 89 millimeters per hour on, I think it was an 8-year-old child. So I must say that I'm tempted, and if you're very confident, you look through field to field and note, yes, the platelet count is high, but they're all normal morphology. I might make a note under my film comment to say reactive thrombocytosis, because that's important. And of course, if you've got an ESR, that's proving it's an inflammatory condition, and reactive thrombocytosis can be probably helpful. But you should be a fairly experienced morphologist before you say that. Okay. So that's the end of a very long pediatric session. I have divided it, as I said, into red cells, white cells, and platelets. And remember, just if you want to go back to some of those disorders which we didn't discuss, like the JMML, or the TAM, transient abnormal myelopoiesis, or the ALL, acute leukemia, it's all there in those other sections. but just be mindful, look very carefully at the lymphocytes of children. Baculation is not a normal feature. It can be a feature look at the lymphocytes, neutrophils. Speculation can be a feature of old blood. You might like to look at if you think it's old blood and you see vacuolated neutrophils, you often can see dying neutrophils on the blood film. Yeah. Okay. So thank you very much for your attention.